Yes, sir. Clearly audible, sir.
Am I visible?
Yes, sir.
Yeah. Sorry for the technical glitch again and again. So, moving on to the next slide, the electronic medical records based on glyclazide, real world evidence from UK actually. So, the real world effectiveness of glyclazide modified release versus sitagliptin. This was the number taken were 1986, and it was a study for 9 years actually. And you can see the different outcomes with sitagliptin. And the primary outcome, the time to get the A1C below 7%, that was the. And the secondary outcome, time to get back the A1C to around or less than 6.5%. And again the secondary outcome is time to the A1C reduction of more than 1% actually. And the rapid reduction of glycosylated hemoglobin levels can help prevent long-term complications, the risk of complications. And early achievement of glycemic control has been associated with better long-term the outcomes, that is called the legacy effect. And Lighty Repong and et al. Showed that the patients with HbA1c of around or more than 6.5% during the first year of the treatment were at higher risk of micro and macrovascular events, while those with around or more than 7% during the first year had a higher mortality risk. So the glyclazide MR led to a greater probability of patients achieving glycemic targets versus the DPP4 inhibitors. So the take home message is the initial first year counts a lot for any type 2 diabetic patient. If the A1C is above 6.5 or more than 7% in the first year, the mortality risk is very, very high. And you can see these the bar diagram, the glycemic control with the glyclazide XR actually. So the glyclazide XR, that is extended release, shows the maximum reductions of the HbA1c, that is reductions by 1.04%, and metformin respectively the 1.01 and the glimepiride 0.97, sitagliptin 0.72 and the vildagliptin 0.69 and the dapagliflozin 0.73 and the saxagliptin 0.67. And you can see the maximum A1C reductions with the glyclazide, the extended release actually. And the improved control with the progressive uptitration also, you find the 1.78% decrease in the mean HbA1c across the HbA1c spectrum you can find, and 2.3 reduction in mean HbA1c range of 8 to 10%. This is according to the easy dia study actually. So the A1C reductions in Indian patients according to the X-ray study, about 8 to 10%, 10 out of patients were able to achieve glycemic control, that is the A1C of less than 7% with the glyclazide XR 60 milligram, and 1.5% A1C reduction was seen according to this particular study with the glyclazide 60 milligram extended release. And the guide study, the glyclazide MR versus glimepiride, more or less the glyclazide MR is at least as effective as glimepiride with regards to reductions in the glycosylated hemoglobin. And from baseline to 27 weeks, you can find the glyclazide, the bar diagram. From the baseline of 8.4, the HbA1c was brought down by 1.2%, that is 7.2%, and the glimepiride from 8.2 to 7.2% respectively, that is 1.2% reduction was seen with the glyclazide, and 1% of A1c reductions was seen with the glimepiride respectively. And the A1c in the intensive arm for 5 years, this is advanced actually, the 1% reduction was seen, and then the total number of subjects was 4499 actually. And maintaining euglycemia, the glyclazide treatment durability, and maintain control over 5 years in advanced trial actually. You can clearly see this, the figures. And safely towards euglycemia, glyclazide, low risk of hypoglycemia, as we have discussed already. The low risk of hypoglycemia with glyclazide, you can compare this on the left hand side. You can see this the night time and the breakfast, lunch and the dinner, the spikes and all, and you don't find any sort of the hypoglycemia. It is a biphasic pulsatile glucose dependent insulin secretion and the restoration of early insulin peak and all, and this shows the less, very less risk of hypoglycemia with glyclazide actually. And this has led us to go on to this particular glyclazide can be used safely during Ramadan because it doesn't produce actually the hypoglycemia. If this particular molecule glyclazide is taken the post iftar, actually the prior to the iftar meal, this produces the minimal incidence of hypoglycemia when compared to sulfonylurea. Overall, the incidence was 13.2%. Whereas glyclazide had a very less incidence of hypoglycemia of only 6.6 respectively, and glimepiride 12.4 because it is long acting actually, and the glibenclamide. And mind you, once again, the take home message is never give the extended release or the modified release during the Ramadan fasting. You have to use only the plain glyclazide, either the 40 milligram or the 80 milligram depending upon the given patient actually. And the glibenclamide at the highest because it is the longest acting sulfonylurea, which are 19.7%. And the DPP4 sitagliptin had similar risk of hypoglycemia when compared to the glyclazide. It was 6.7%. And this is according to the Al-Sifri et al. And on the right hand side you see this according to the Indian context, the Aravind and et al. They showed the overall sulfonylurea was 7.3%, glyclazide was 1.8%, glimepiride was 5.2%, and glibenclamide 9.1%, sitagliptin 3.8% respectively. The incidence of symptomatic hypoglycemia during Ramadan fasting in all the randomized controlled trials. And glyclazide during Ramadan, and the maintenance of glycemic control with the evening administration of a long-acting sulfonylurea in male type 2 diabetes patients undertaking the Ramadan fasting is the original paper from clinical practice. Even the fasting patients can safely maintain glycemic control with evening administration of glyclazide MR60. And the diabetes research and the clinical practice, the real world study in patients with type 2 diabetes mellitus treated with glyclazide modified release during Ramadan fasting, the Ramadan study said the proportion of patients reporting around one or more symptomatic hypoglycemic episodes during Ramadan was as low as 2.2% with the glyclazide. And safely towards euglycemia, the glyclazide, the cardiovascular outcomes. The glyclazide and the cardiovascular safety, you can see the basic difference between the other sulfonylureas and the glyclazide because it acts on the pancreatic sulfonylurea receptor 1 specific. Glyclazide is very specific to sulfonylurea receptor 1. So as well as the ischemic preconditioning, it favors ischemic preconditioning. So the differential affinity for sulfonylurea receptor 1 receptors leads to the controlled and the pulsatile insulin release, and the selectivity of the pancreatic potassium ATP channels preserve protective ischemic preconditioning. That is, you see on the left hand side the glyclazide XR that doesn't act on the sulfonyl U, the receptor 2, which is in the cardiac cell, whereas the other sulfonylureas they act on the sulfonylurea receptor 2, which is present in the cardiac cell. So thereby it favors the glyclazide favors the ischemic preconditioning. So it is cardiovascular safe molecule. And glyclazide has lower CV risk than other sulfonylureas, insulin secretagogues. That is, this is according to the Danish registry. And glyclazide has the lower all-cause mortality and cardiovascular related mortality risk. And you can see the figures favoring the glyclazide. And glyclazide did not increase the risk of stroke. and measure macrovascular or the microvascular events, and you can see the 10% of a relative risk reduction of combined major and micro and the macrovascular events, that is the statistically significant, the p value being 0.013. It is not very significant, but it is statistically significant. So the relative risk reduction is 10%. Now glyclazide and the renal outcomes, and creatinine versus glimepiride actually. So you can see the take home message out of all this is this particular insulin secretagogue sulfonylurea, glyclazide is the only one sulfonylurea that can be used at any stage of EGFR, that is starting from stage 1 to stage 2, stage 3, A, B, 4 and 5, along with insulin, I mind you, and you have to reduce the dose because of unexplained hypos, what we see in the stage 4 and stage 5 actually. So this can be used, and the one more drug better than this is the linagliptin actually. Linagliptin is the only molecule that can be used in any EGFR, let it be ESRD or even the during the dialysis or even during the transplant and post transplant also, even that can be used in the new onset diabetes actually. Linagliptin can be used in the new onset of type 2 diabetes after the transplant, that is post transplant new type 2 diabetes also it is recommended. Like this, we have got a molecule but very economical and affordable price, like this particular glipizide, not the extended release, can be used at all the stages of renal impairment, let it be mild to moderate to severe impairment, that is ESRD or ESKD. But all the time I advise you to don't go by creatinine. It is a decisive parameter. You always try to calculate the estimate glomerular filtration and then only proceed. See, these are all after the insulin only. I once again mind you, please, insulin plus linagliptin or insulin plus glimepiride, that's it. And 21% reduction in the nephropathy actually. This is seen in the intensive arm of the advance actually, and the 65% reduction in the risk of ESRD and 20% of reversal to normal albuminuria was seen in the 5-year study of advance actually. You can clearly see the right hand side, the normal albuminuria or the albumin excretion ratio, that is the rate, albumin AER is that is less than 30 milligram per 24 hours, that is normal, and the albumin excretion rate 30 to 300 is, we call it microalbuminuria. Now the ADA 2021 guidelines, they have replaced this particular microalbuminuria with UACR, that is urinary albumin creatinine ratio, that is, so the macroalbuminuria is anything above 300 milligram per 24 hours is called macroalbuminuria, and followed by the mild impairment to moderate impairment to the severe impairment, that is end stage renal disease or the end stage kidney disease. So you find the favorable effects of the molecule glyclazide, and 46% reduction in ESRD in the intensive arm of advance on, that is ongoing, advance ongoing. You can see very clearly in the left hand side or even in the right hand side, better outcomes with preserved kidney function with glyclazide. And according to the National Kidney Foundation NKF, and it is part and parcel of the KDOQI, that is KDOQI is part and parcel of National Kidney Foundation. It is Kidney Disease Outcome Quality Initiative that gives the diet plans and all to the patients suffering from the kidney impairment and all. So according to that, the glyclazide is the only molecule that can be used at all the levels of EGFR. That's what I said. The 46 to 60 is stage 3A and 30 to 45 is stage B. The stage 3B and less than 30, that is ml per minute per 1.73 meter square of surface body area. So glyclazide can be used in all the stages of kidney disease and all the levels of EGFR, whereas glimepiride has to be used with caution in even in stage 3A or even in stage 3B, and even you are supposed to avoid in ESRD because of the long duration of the action of glimepiride. So we should differ using the glimepiride in renally compromised patient. You have to be very cautious. So you better switch over to the glyclazide. Glyclazide can be used without any dose adjustment in CKD 3, 4, 5, that is chronic kidney disease, stage 3, A and B, 4 and 5. So can be safely used according to the National Kidney Foundation, NKF. And safely towards euglycemia, the glyclazide and the weight neutrality, and no significant weight gain in advance. So you can see this is almost very minimal weight gain, and it is not at all significant with glyclazide as per this particular advanced trial. And the weight neutrality over the 5 years, you can very clearly see it is plus or minus 1 kilo, and finally after the 5 years it has touched the original weight. That's it. So glyclazide, the modified release used for 5 years did not improve even a single kilo as per the advanced trial. And better weight and body mass index control during Ramadan. Actually, it's a diabetes research and clinical practice. The real world study in the patients with type 2 diabetes mellitus treated with glyclazide modified release during the fasting, the Dia Ramadan study, which we had discussed already, that was published in this particular diabetes research and clinical practice. See, you can see this, the body weight did not change and the BMI did not change. Actually, it is hardly 28.4, and after that it is 28.2, and the weight was 76.5 kilogram, and the weight after that was 76.1, and the p-value is less than 0.001, that is very statistically significant as far as body weight is concerned. And respectively the body mass index, BMI, is also, the p-value is less than 0.001, that is also statistically very significant. It is minus 0.5 kilo that the difference is. And the summary is, the glyclazide is a sulfonylurea receptor 1 specific and sulfonylurea which favors the ischemic preconditioning, causing the biphasic glucose dependent insulin secretion. And glyclazide is at least as effective as glimepiride, either as monotherapy or in combination. And glyclazide helps in navigating patients safely towards glycemic goals with low risk of hypoglycemia as compared to the other sulfonylureas. And glyclazide has favorable cardiovascular and the renal outcomes and is weight neutral. And glyclazide helps in glycemic control while fasting and does not need the dose adjustment even in the CKD, that is chronic kidney disease. And coming to the final slide, and you can see the benefits of the glyclazide all we summarized and we narrated for the last 1 hour. And the sulfonylurea with the difference is certainly is the glyclazide molecule, because it has got the unique mechanism of action like pancreatic beta cell, the sulfonylurea receptor 1 specific, it doesn't act on the sulfonylurea 2 receptor actually, which is present in the heart. So it is cardiovascular safe molecule. And the controlled and pulsatile insulin secretion we see with the glyclazide. And as far as efficacy is concerned, it is on par with the other sulfonylureas, and the treatment and the durability is perfectly okay with this. That makes the ideal choice, the glyclazide is the ideal choice in the management of type 2 diabetes mellitus in case the sulfonylurea is being considered, that is after the metformin. And if the patient, according to the latest 2021 guidelines of the American Diabetes Association, or even the EASD 2021 guidelines, what they see is the patients at risk of atherosclerotic cardiovascular disease or the established cardiovascular disease, atherosclerotic cardiovascular disease. After the metformin, you are supposed to use either the SGLT2 inhibitor or a GLP-1 analog or both. But the Indian scenario, I think we have to choose this glyclazide as a second molecule, and after that the metformin added to that the glyclazide. After that we can definitely go for this what the recommendations say, the SGLT2 inhibitors or the GLP-1 receptor agonists or the DPP-4 inhibitors, because it is compatible with all the molecules, even with the insulin, even with the metformin, even with the DPP-4 inhibitors, even with the GLP-1 receptor agonists, even with the SGLT2 inhibitor. So glyclazide is compatible to all the drugs which are present in the armamentarium in the treatment of the type 2 diabetes mellitus, because it has got the very specific features like very low risk of hypoglycemia and a good cardiovascular established safety and a good established renal safety and the weight neutrality. These are all the factors which make this particular glyclazide, the modern sulfonylurea, the edge over all the other sulfonylureas, and that makes the difference. So by that I just thank you for your patient listening. I just sign off. This is Dr. Sepuri Krishna Mohan, Kurnool. Thank you so much. And if you have any questions, please you can put it in the chat box. I am glad to take the questions, and we'll now move on to the QA session. So any doubt, okay, may not be glyclazide, may not be related to only the sulfonylureas. You have any doubt, feel free to just type your question, type your name, so that I will be able to take up your questions, please.